Good afternoon, everyone. Welcome to Toward Resilient Aging, Reducing Influenza Impact on APEC's Elderly. My name is Hector Castro. I am Vice President of Health and Life Sciences at Access Partnership, and I will be moderating this session, both here at Songo Convention in Incheon and online via Zoom. Before we start with the content of the session, I would like to give a quick reminders. First one, this session is being recorded. There is interpretation available in Chinese, Japanese, Korean, and Vietnamese. Online participants, please use the Zoom interpretation icon to select the language of your preference. And for those here in person, please scan the QR code to access the Zoom link and use your own headphones or earbuds for listening. One other recommendation for online participants, please stay muted unless speaking and use the chat for questions or comments. And for those here with us, please kindly speak into the microphone so everyone, including our interpreters and online attendees, can hear you. As many of you know, seasonal influenza poses a growing threat to public health, particularly for older adults who account for the majority of flu-related hospitalizations and deaths. This challenge is especially urgent for APEC economies, which are experiencing rapid demographic shifts. In many of these economies, life expectancy is ranging 80 years of age, and as way of example, in countries like Japan, 31% of the population is over 65 years old, and this share of the population is expected to rise to 37% by 2050. The challenge is especially urgent for APEC economies, which are experiencing rapid demographic shifts, as I said before, and our goal today is basically to address some of these challenges and opportunities. The goals for today's session are to share best practices to reduce influenza burden in aging populations. We will also discuss about strategies to strengthen surveillance, vaccination, and treatment programs. And we will build consensus around actionable recommendations that support healthy aging, health systems resilience, and pandemic preparedness. To open our program, it is my pleasure to invite remarks from Dr. Cheong from the Republic of Korea, who is the chair of the Korea Expert Committee on Immunization Practices, and is also a professor at the Department of Infectious Diseases at the Korea University College of Medicine. Dr. Cheong is a leading expert in adult infectious diseases and immunization policy in the Republic of Korea, has held several leadership positions, including past presidency of the Korean Society of Infectious Diseases and membership of national advisory groups on vaccination. And of course, she has authored numerous publications in the field. So please welcome Dr. Cheong.
Good afternoon, distinguished delegates, colleagues, and guests. It's a great honor for me to welcome you to this important policy dialogue on behalf of the Republic of Korea. I sincerely thank to the APEC Health Working Group, the organizing partners, and all participating economies for your commitment to public health and healthy aging. We are especially pleased to host this discussion in Korea, one of the fastest aging society among APEC members. The issues we address today are both timely and critical to the health and well-being of our populations. Influenza continues to pose major challenges across the Asia-Pacific, especially for elderly groups. Globally, those aged 65 and older account for the majority of flu-related hospitalization and deaths. due to the age-related immune decline, chronic conditions, and the increased risk of complications. Korea is no exception. In its flu season, we faced significant disease burden among the elderly population, despite of high vaccinations in Korea. Even though vaccination remains the most important and effective preventive measures, the aging immune system requires further tailored approaches. This underscores the need for the age-appropriate immunization strategies that address immunosenescence. For example, immune-enhanced vaccines such as high-dose influenza vaccines are designed for provide strong protection in the elderly people and have shown improved outcomes. Their value is increasingly recognized both globally and here in Korea. Several economies have adopted differentiated vaccine strategies based on age or risk groups. Korea is also reviewing evidence-based options to enhance protection for our elderly populations. As we consider these approaches, today's dialogue offers a valuable opportunity to exchange insight on implementation, equity, and sustainability. At the same time, robust data and surveillance are essential. Real-world evidence helps quantifying disease burden, inform decisions, and evaluate the policy impact. APEC plays a key role in this effort. By sharing experience and best practices, we can build a stronger health system and promote health aging across the regions. I look forward to today's dialogue and the contribution from across our economies. Thanks once again for your participation and dedication to this important work. Thank you.
Before moving forward, I would like to remind us that this meeting is being recorded for those online and also for those here in the room. We now move into a series of presentations that will ground today's dialogue in the latest evidence and experience. Each speaker brings a unique perspective from research policy and regional engagement. So I'm going to introduce the first presenter. He is Mr. Eric Obscherning. He's Director of Ad-Access Partnership and will be presenting on the draft recommendations to prevent excess influenza burden in older adults in APEC economies. So welcome, Eric, and the floor is yours.
Good evening, good morning. We're here today because seasonal influenza continues to impose a substantial burden, a disproportionate burden on older adults, those aged 65 and older. This remains one of the most persistent yet preventable threats to this population. Adults 65 and older account for up to 85% of flu-related deaths each season, up to 70% of hospitalizations. So this is a staggering health issue, but it's also a demographic issue. It's also a systematic vulnerability in our economies, in our societies, in our health security infrastructure, and in the context of population aging. There are several compounding factors that lead to this disproportionate burden on older adults. Demographic changes are simply putting more older adults at risk by proportion and by absolute number. There is inconsistent vaccine access and uptake, especially tailored vaccines for this population. There are continued gaps in surveillance, in epidemiological data, public health data. delayed diagnosis and underdiagnosis, and atypical symptom presentation, limited use of tailored immunization strategies that are appropriate for this age group, and various other health system constraints. So our task today and moving forward from this dialogue is to turn this set of challenges into a shared regional agenda. So that's why we're developing the recommendations paper to identify and scale practical solutions from APEC member economies. So what does influenza cost society? Well, we need to act now not just because costs are rising, but because delayed action increases the human toll and the economic toll. And understanding the costs of influenza is vital to designing policies that work. The direct costs are visible and oftentimes obvious. Hospital stays, diagnostic tests, antiviral therapies, long-term care. These are immediate, oftentimes measurable costs that health budgets are already struggling to absorb, let alone increase. But indirect costs are just as critical. Lost productivity, caregiver absenteeism, long-term disability, mental health impacts, and certainly the loss of life years and intergenerational support. So these are the costs that ripple out in our societies and in our economies that are harder to quantify, but they carry enormous economic and societal consequences. So to develop sound policy, to come up with a solid, evidence-informed, actionable paper with recommendations, we need to quantify and recognize these full costs. And as economies embark on their own policy reform and policy improvements, you too need to fully appreciate and start to quantify these costs. So there are several strategies that we have already identified in the draft recommendations paper, 7 to be precise, and these are all based on existing evidence and existing case studies from around the region, and they must be coordinated. That is absolutely critical. For vaccination, we need to develop clear evidence-based policies with tailored flu vaccines for older adults. We need to improve vaccine uptake through outreach and public awareness. We need to expand surveillance and better estimate burden, which Thailand Ministry of Public Health has championed. We need to promote use of rapid and sensitive diagnostics, as well as ensure prompt access to antiviral therapies, which US FDA and US CDC have done. We need to strengthen infection control in long-term care facilities, as initiatives in Hong Kong, China have demonstrated. We need to integrate flu prevention and control into broader healthy aging and primary care strategies, as Singapore has done in the Healthier Singapore initiative. So as you can hear, for each of these, we're actively collecting case studies from APEC economies to validate these recommendations, but also to demonstrate that there are examples of success, and also to provide actionable next steps that economies can implement in their own context, and especially ones that are fit for purpose. So following today's dialogue, as a next step for you to consider and engage and participate in, we're going to revise the draft recommendations paper to reflect all of your feedback, all of your insights, all of the discussions today, all the chats, any subsequent questions and answer that we get by email. And our goal is for this to be a living, practical document that supports policy innovation across the region. The positive impact of implementing and sustaining these strategies, because just to develop a new strategy and put it on the shelf is not enough. It requires implementation and sustained adherence. But the positive impact is reduced flu-related deaths and hospitalizations among elderly, as well as a lessening of the burden of seasonal epidemics in general, and really an embodiment of the core health working group vision, which is more resilient health systems resilient to emerging infectious threats, and certainly stronger environments for healthier aging. So I'll let the real experts get into it, but I think this is a wonderful opportunity for us to take stock of what's working, take stock of what's not, and use APEC as a platform to improve this environment in all of our economies. Thank you very much.
Thank you, Eric. Now, the next presenter is Dr. Litjen Tan, J. Tan, Chief Policy and Partnerships Officer at Immunize.org, co-chair of Global Influenza Initiative, and co-chair National Adult and Influenza Immunization Summit, who will be speaking about the imperative to protect our elderly population from influenza. Welcome, Dr. Tan.
Awesome. You can tell Hector's tall because I have to lower the mic. So thank you all. I'm honored to be here, and I really appreciate the chance to talk to all of you about your policy dialogues for your economy here, because I think this is something that's been very close to my heart. I've been working in influenza and adult immunizations for almost 30 years now, and I can tell you every time I look at influenza, there are things that change and there are things that don't change. And what doesn't change is what I'm going to present is a United States perspective, because that's where most of my data comes from. But even as I look at the US data, I can tell you that a lot of it is applicable globally too. And as I work with the Global Influenza Initiative, I can tell you that as I look across European economies, as I look across Asian Pacific economies, there are so many parallels that we can take into the implementation part of this plan that has been described to us. So I'm looking forward to talk a little bit about that in our panel discussion. But my job today is to essentially set up the stage for all of us to kind of move forward. I think it's already been covered a lot by Eric here in terms of some of the things that he's mentioned. So I'm not going to go into a lot of detail. I think it helps me because I don't have to work so hard, which is really nice. But first, talk about the global burden of influenza. So this is data from 13 years of CDC collected data every year. And you can see this pyramid. And the pyramid basically shows you deaths on the top, hospitalizations in the middle, and of course, actual illnesses at the bottom. And of course, the numbers vary because some seasons are harder, some seasons are easier, right? And so I think you take a look at that. But the most important statistic has already been pointed out is that across those 13 years of data, adults 65 years of age and older accounted for 45 to 67% of related hospitalizations and about 62 to 87% of deaths. So we're losing a lot of valued lives in the older population. And as importantly, they're being hospitalized. There is morbidity, there's suffering, and with that comes costs. So I'll talk a little bit about that as well in my next slide after this one. So just to remind all of us, there is significant morbidity, which means, pain and suffering, mortality, which is death, and of course, economic burden, because you have to take care of people who have influenza, right? And we already heard this multiple times from Dr. Cheong, for example, that vaccination is the most effective preventive measure to prevent all of this. So when we don't do this, it's on us. We are failing our older population. We are failing our goals for healthy aging. So we need to take this seriously. And I think I want to point out that even with the current changes that we have in our advisory committee immunization practices in the United States, and I say that with a wink, they still have recommended influenza immunization in the US for 6 months of age and older, because the data is so clear that influenza vaccination reduces morbidity, reduces mortality, reduces costs. So here it is. Here's some of the cost burdens of influenza. This is United States again. Annual direct medical costs. So those are the costs that was shown on the left side of Eric's graph slide. More than $10.4 billion a year. indirect costs from lost productivity and all these other indirect measures that were shown on the right-hand side, $16.3 billion a year in the United States. And of course, as we all know, we learned this through COVID and we continue to learn this, is that there's a high burden on the healthcare system during peak influenza season. And so here are the benefits of vaccinating against influenza, as if I need to spend more time talking about this, right? If you hear the impact, you're going to say to me, LJ, vaccinating is a no-brainer. But for some reason, we don't do it very well. So I'm going to be here. I'm going to tell you again, this is why we need to do it well, okay? So just to remind everybody, the burden is on that right-hand side. But think about what flu vaccination does. Reduces hospitalizations by 40 to 60%. So all those people that we are putting into hospitals, they don't have to be there. All right? Because 40 to 60% of them can be not hospitalized. There's a significant reduction in deaths, especially in the older adults when they get vaccinated. And of course, vaccination also protects indirectly all the high-risk groups such as infants, the elderly, and immunocompromised individuals. The other thing that I don't put here is quality of life. When I go talk to my older folks, I volunteer a lot in long-term care facilities, and I talk to them, they don't come to me and they don't say to me, LJ, I'm worried about passing away. Death actually is not something they ask me questions about. They ask me questions about things like, if I catch influenza, what will happen to my life? Right now, I cook my own dinner. I have a caregiver come in. She helps me a little bit, but I get to go and do a little bit of shopping. I can tell you, and I tell them, that influenza can take all that away. And that's what matters to the elderly population, that quality of life, which is not shown in this. So some of the population level impacts of flu vaccination. Community immunity, right? If you can protect a large number of people, it will reduce transmission. I want to remind all of us that influenza is transmissible up to 24 hours before you even show symptoms. So I can be walking around now and I can cough on Dr. Cheong, and 24 hours from now have influenza, and unfortunately I have just infected her. But because South Korea has such a great immunization coverage rate, she's probably protected. The other thing has already mentioned, it improves public health resilience during epidemics. If you can vaccinate your elderly population every year, when you have an epidemic or a pandemic, guess what? You can vaccinate them again. You can take care of that business, right? Because you're ready to go. And then finally, as we talked about surge capacity, it reduces that burden on hospitals as well. So the cost effectiveness of flu vaccination, I'm just going to spend a little bit of time here. It's very cost effective. In fact, in some situations, it's even cost savings. As I already mentioned, it reduces your spending on hospitalizations and on the complications that come from getting influenza in the elderly population. And in the Advisory Committee on Immunization Practice in the US, cost effectiveness is one of the factors that is actually looked at in making that final recommendation. So when the ACIP in the US makes a recommendation for flu vaccination 6 months and older, that's our recommendation. It is based on the fact that it is cost effective and across that entire lifespan, and especially so in those over 65. Okay, and this is the public health impact of elderly vaccination. I'm not going to spend a lot of time here remembering that reduces illness and mortality, reduces the use of healthcare resources, and again, in terms of those who are living in long-term care facilities, which are aggregated settings where people are close to each other, you can increase indirect protection, right? Because if you're vaccinating that population, you're protecting the transmission within that population as well. So there is a huge benefit of vaccinating those over 65. And then this is a cost-benefit analysis. I do a lot of work in adult immunizations. Influenza is a really, really remarkable thing because it opens the door to talk about all these other adult vaccine-preventable diseases that are important as well. On this graph, there are 4 adult vaccine-preventable diseases that are here. I'm not going to talk about the other 3 because I've been told to talk about flu. But pointing out flu, which is on the left-hand side of each of these 3 different segments, right? So you see no vaccination. This is a cost-benefit analysis over the course of 30 years, predominantly focusing on just direct costs. Over 30 years, you can see about almost a $450 billion cost to the United States if you do not vaccinate against influenza. You move over 1, and if you look at the current immunization coverage rates that we have in the US, which varies from about 65% in the 65 and older, right, then what you have, and this actually looks at 50 and older, what you see is you see that reduction with the current vaccination coverage rates. And then if you move one step over, they made the modeling look at what happens if you then improve the coverage rates. And again, you see a substantial reduction again in those direct costs as well. I think what is not measured here is obviously the indirect costs, and that's harder for them to model, which is why that's not here. But the point of this, once again, is that in addition to the other vaccine preventable diseases, influenza remains one of those large cost drivers, and therefore is one of the most cost-effective. Influenza vaccination is one of the most cost-effective ways to go ahead and reduce those costs. Not going to spend a lot of time on ACIP. Just, I think many of you know that the Advisory Committee on Immunization Practices uses a lot of data to develop recommendations for influenza vaccination use. And the data are based on efficacy, safety, as well as the public health impact. We use at the ACIP, I was a member of the ACIP until 2012. We use at the ACIP a grade system that results in 6 domains of examination: public health problems, benefits and harms, values and preferences, resource use, which includes that cost, equity, and then acceptability and feasibility, which is how the vaccine is accepted by not just providers, but also by the public. When you look at all of those, the ACIP in the US came up with the recommendation that everybody 6 months of age should receive an influenza vaccination. Right? So this is a really broad recommendation, and the ACIP, looking at all those factors that I showed you earlier, has decided this is the best way to do it. The other thing also the ACIP has said is that we also need to start focusing on older adults, and they actually have a preferential recommendation in the United States for using, as Dr. Cheong suggested, those enhanced vaccines for older adults. But why focus on older adults? Some of this is going to be repetitive, but you know what they say? You say it once, you say it twice, and you say it 3 times, and then maybe your audience will finally recognize it, right? So here it is. Remember, Dr. Cheong suggested this as well. Why older adults are at higher risk? Aging weakens the immune system, reducing the ability to fight influenza. There is immunosenescence, right? So keep that in mind. Remember, in terms of quality of life, there's also something called immunoflaging, which is where the high increase in inflammation that comes with getting older results in actually exaggerated complications from influenza infection. When you get those exaggerated complications, you result in a loss of quality of life. So keep that in mind as well. As already mentioned earlier, people over 65 account for 70 to 85% of deaths. And of course, in the older population, there's an increased risk of hospitalization, increased risk of long-term disability, increased risk of pneumonia, so on and so forth. Dr. Cheong and I were just talking a little bit earlier on about also older adults, especially the adults 50 to 64. Many of those groups have chronic conditions that they are not aware of. And if you are not aware of a chronic condition and you catch influenza, that flu is going to take you out. It's going to make you really sick. So that's the other reason why the US has these broad recommendations, because we know that people that are generally considered healthy, 50 to 64, may have an undiagnosed chronic condition that will cause them complications for influenza. So by vaccinating them with this broad routine recommendation, we can reduce the cost as well. So some of the things I want to kind of mention that the ACIP has talked about: standard dose vaccines are less effective. They're not effective. They're just less effective in older adults. And we do have in the United States high dose and adjuvanted flu vaccines that will improve the immune response in seniors. And in fact, the ACIP, as I suggested earlier, recommends using those high dose vaccines, those enhanced vaccines, adjuvant vaccines for individuals 65 years of age and older. So this is the preferential recommendation. I was supposed to have taken out those name brands, so I'm going to move really fast past that. But basically, those adjuvanted vaccines are essentially there's adjuvanted and then there's high dose vaccines, and both of those are recommended for all those adults 65 years and older. And I do apologize. I should have taken out those name brands, and they did not get taken out. The final thing I want to point out is that the US, we do take 65 and older population very seriously. We have a resource that you can see here. Please take a look at it, influenzadefense.org. It is an entire resource for helping healthcare providers talk about influenza with those 65 years of age and older. So I'm going to just conclude by reminding all of this. I think you know all of this. I don't think I want to spend too much time on this, but basically thank you all. And remind everybody that if you do influenza vaccination correct, if you operationalize it well, then you are going to be prepared for the next pandemic. Everyday readiness is pandemic preparedness. Thank you very much.
Thank you, Dr. Tan. Our next presenter is going to be online. Charlie Humphreys, who is the Director of Corporate Affairs at Asia House, will be presenting on influenza, healthy aging, and economic resilience in Japan. The floor is yours, Charlie, and welcome.
Thank you very much. I'm delighted to be here virtually today. So in this presentation, I'm going to provide an overview of our recent research on influenza, healthy aging, and economic resilience in Japan. And we're grateful to Sanofi for supporting this research. I will take you through some of the key findings of the research and policy recommendations arising from these. So first of all, I want to explain the questions that we sought to answer with this research. We had three key questions. So the first was, what was the relationship between influenza and economic resilience? The second, how should short-term healthcare costs be assessed against long-term benefits? And the third was the role of influenza vaccine investment within the context of broader government priorities. So on my next slide, I will explain our research methodology. So we held a roundtable discussion in Tokyo in April earlier this year. This was attended by virologists, gerontologists, and health economists. We also met with government officials, NGOs, and policy specialists, and interviewed a wide range of key stakeholders from health institutions. And this helped us build a really clear picture of the key issues. We supplemented this unique knowledge with extensive desk-based research, which included a review of scientific studies and analysis of data from the WHO and government departments such as the Ministry of Health, Labour and Welfare. And if we move on to my next slide, I'm going to share the key findings from our research. So the first key point is that Japan's aging population faces greater risk of severe influenza outcomes. What we identified is that the elderly are more vulnerable to severe illness, hospitalization and death. Influenza places a growing strain on hospitals and care homes. We also saw that high-dose vaccines offer better protection for older adults and are cost-effective. The high-dose influenza vaccine offers superior protection for older adults compared with the standard dose vaccine, thereby reducing illness, hospitalizations and mortality. So influenza vaccinations, as we've heard, are a cost-effective health intervention with evidence from many countries, such as the US and France, showing major public health gains and healthcare savings from high-dose vaccine use. The next key finding in our research, sorry, if we just go back, that's it, thank you. Next key finding in our research is that only standard dose influenza vaccines are widely available in Japan, and the uptake among the elderly is just 56% against a WHO target of 75%. I'm just checking if you can see the slides okay and hear me okay at the other end. Hopefully you can, yeah. So in December 2024, Japan's Ministry of Health, Labour and Welfare granted regulatory approval for Sanofi's high-dose influenza vaccine, but it is not yet available under the National Immunization Programme. The next key finding is that barriers to vaccine uptake include misinformation, low awareness, lack of trust, and uneven funding. And finally, we saw that healthy aging supports longer working lives, which is a key government goal in Japan. The government aims for people to work longer, and preventative healthcare is key to maintaining a healthier, more resilient workforce. So in my next slide, I would like to cover the key health impact of influenza. So as is well understood, influenza has a number of serious health implications, particularly for individuals with weaker or compromised immune responses. I'm not going to go through all of the health impacts shown here, as I'm sure you're all very familiar with them. But the key point is that the elderly are more vulnerable to severe illness, hospitalization and death as a result of seasonal influenza. And the elderly are particularly vulnerable because of their immune response. Their immune responses tend to be weaker and they have a higher likelihood of chronic health conditions, both which can exacerbate the severity of the influenza and increase the risk of complications such as pneumonia and bacterial infections, etc. Just to illustrate this, during the 2023-24 season, adults aged over 60 and over in Japan comprised 43% of all hospitalizations, with that figure increasing to 64% in the 24-25 season, which was a particularly severe influenza season. And our research identified that where high-dose influenza vaccines have been used, they've measurably reduced the impact of influenza in patients over 65 and over, and ultimately reduced all-cause mortality rates. So, on my next slide, I'd like to focus on the key aspect of our research, which is the link between influenza among the elderly and economic resilience. So, we identified that influenza places a significant economic burden on Japan's healthcare system. A 2024 study indicated that influenza-related hospitalizations cost approximately 850,000 yen, or around $5,750 per patient for respiratory cases, and approximately 900,000 yen, or around $6,100 where cardiovascular conditions were also involved. Another study from 2017 reported that Japanese inpatients with influenza stayed in hospital for an average of 12.5 days, with total healthcare costs averaging approximately 875,000 yen per admission, which is around $5,950. So clearly a very significant impact when you think of the total numbers. Secondly, the high-dose vaccine is proving to be a cost-effective investment in other markets, including France and the United States. A study conducted in France in 2024 showed that switching from the standard dose to a high-dose influenza vaccine for older adults was estimated to prevent over 57,000 influenza cases, over 13,500 GP visits, and over 750 deaths, and possibly as many as 15,750 hospitalizations. A study in the US found that over a 10-year period, the high-dose vaccine prevented more than 1.3 million influenza cases, over 520 cardiorespiratory hospitalizations, and nearly 74,000 deaths. And that was also generating an estimated savings of $4.6 billion and delivering a return on investment of more than 200%. Thirdly, Japan's demographic shift presents a dual challenge: a shrinking workforce and an aging population. So Japan has the highest life expectancy at 84.5 years, as well as a declining birth rate. And this trend is projected to continue to 2050, resulting in a smaller workforce to support the wider population. In this context, the Japanese government has introduced policies to support workforce participation up to the age of 70. In 2021, the government revised the Act on Stabilization of Employment of Elderly Persons to require companies to make efforts to secure employment opportunities for individuals up to the age of 70. This includes steps such as raising or abolishing the mandatory retirement age and introducing continuous employment systems under which an employee who reaches the mandatory retirement age would then be re-employed. The Ministry of Health, Labour and Welfare also provides subsidies to employers who transition older fixed-term contract workers into permanent positions. And these policies are essential to meet the objectives set out by Japan's Aging Society Policy Council, which aims to build an ageless society whereby people of all generations, including the elderly, can take full advantage of their skills and abilities and play an active role in a range of areas. So if we look at the charts here on the right-hand side, we can see why it is essential for Japan to extend workforce participation among older adults for long-term economic resilience through this demographic shift. As Japan's population declines, the working age group is also set to fall. The WHO projects that the number of people aged 20 to 64 in Japan will decline from 67.5 million in 2023 to 50 million in 2050, reducing its share from 54% to 48% of the population. And as you can see in this chart, this means that there'll be a smaller population of taxpayers to support a larger population of the elderly, which will place increasing pressure on public finances and pensions. So expanding employment among older adults can help offset this labour shortage, support productivity and maintain consumer demand, all of which are vital for sustaining growth in GDP. So on my next slide, I'd like to share the policy recommendations in our report. The first recommendation is that high-risk populations should be prioritised in immunisation policy. Results from scientific studies suggest that the high-dose influenza vaccine should be included in Japan's National Immunization Program B for adults over 65, aged over 65 and older. Its superior efficacy compared to the standard dose vaccine offers significantly better protection for a segment of the population that is particularly vulnerable to influenza and related health complications. Second recommendation here is to strengthen public awareness and address vaccine hesitancy. Improving health literacy is essential to increasing vaccine uptake. Many older adults remain unsure of the benefits of influenza vaccination, and they're often unaware of the newer formulations such as the high-dose vaccine. Health literacy, which is the ability to access, understand and use health information to make informed choices, remains relatively low in Japan compared with many European countries. The third recommendation is for support of research and data collection. Robust, timely data is essential to understanding the full impact of high-dose influenza vaccination and guiding future public health decisions. This includes data on uptake, outcomes, cost effectiveness, and potential indirect benefits, such as reduced burden on caregivers, fewer lost workdays, etc., etc. The roundtable participants in our research cited lack of detailed data and fragmented data sets in Japan as a limitation to assessing the effectiveness of vaccines. A national vaccine registry, as opposed to the current system of municipal records, could reduce that data fragmentation across the country. The fourth recommendation is to expand equitable access and delivery. Introducing the high-dose influenza vaccine into the National Immunization Program Category B would improve annual access for those aged 65 and over. Such a step would require the national government to cover 30% of the vaccine cost, while municipal governments would be responsible for deciding how much of the remainder would be borne by individuals. Our roundtable participants emphasised that cost is a key lever to increased uptake among older adults who typically have lower disposable incomes. So reducing or eliminating co-payments through full or partial subsidies could help Japan achieve the WHO's recommended influenza vaccine coverage rate of 75% for older adults, which, as I said earlier, is significantly above the current rate, which is 56% at the moment. And the final recommendation is to enhance collaboration across key stakeholders. Policy development and implementation should involve a broad coalition of actors, including government bodies, research institutions, industry partners and patient advocacy groups. Encouraging collaboration between academic researchers and public health agencies can support the generation of real-world evidence to guide policy decisions on high-dose influenza vaccines. Similarly, partnerships with patient advocacy organisations, particularly those representing older adults or individuals with chronic conditions, can enhance public engagement, promote vaccine confidence, and help tailor outreach efforts to the needs of vulnerable populations. Well, that brings me to the end of my presentation. In the next slide, we have a QR code which you can scan and access the report. The English language version has just come out, and the Japanese language version will be published very soon. I'm afraid I don't have, I can't stay on for the panel discussion because I have another commitment, but I really wish this forum all the very best. And if anyone has any questions, please do get in touch. You can go, those are our references there. You can, through where the report is, you can find contact details and get in touch, and we're happy to provide any more detail for anyone who's interested. Thank you so much.
Thank you, Charlie. Thank you very much. Thank you also to all three speakers for helping us set the stage for our policy exchange. Your insights are essential to shaping our collective response to the influenza burden in aging societies. As you can see, we have the QR code in case there are any questions. Maybe we have time for one or two. And for those online, please submit your questions in case you have any via the chat on the Zoom platform. So maybe let's give it like 1-2 minutes. And if we hear none, we will move to the next segment of today's session. Good. So we now turn to a panel discussion titled Challenges and Successes in Reducing Influenza Burden, Case Studies from APEC Economies. We will hear from panelists that will domestic experiences about key challenges and lessons learned. And please join me in welcoming our first panelist, Dr. Cheong from Chinese Taipei, Deputy Director General of Taiwan Centers for Disease Control, who is going to present on their experience. So the mic is yours, Dr. Lo. Thank you.
Thank you. Good afternoon, everyone. I will briefly share our public health strategies to reduce the impact of influenza among the elderly with a few PowerPoint slides. So let me share. So I want to emphasize that influenza vaccination is embedded in our influenza pandemic preparedness plan since 2005. Among all the major components, you can see that biomedical interventions are very important, including antiviral stockpile. We maintain at least 10% of the antiviral stockpile to meet the requirement for our total population. And for seasonal influenza vaccination, to strengthen our influenza vaccination resilience, we have been promoting free of charge vaccination for all the high-risk population, expanding also the criteria for high-risk population to meet the self-promoted criteria of at least 25% of the whole population can be vaccinated free of charge for influenza vaccine. Of course, surveillance is still very important to guide our risk population and also strategies. We have the laboratory and the clinical surveillance systems. There are multiple integrated in place. On the right-hand side, you can see still the heaviest disease burden lies in the age population of 65 and above, followed by the age group of 50 to 64. They have the highest morbidity and the mortality, which is also a justification of our free of charge vaccination program prioritized to the age group above 50 and also for children as well. I want to use the following slides to illustrate the treatment, but also principally the challenges of achieving a higher influenza vaccination rate among the elderly. As you know, a lot of the regional economies, we are facing an aging society. In my scenario, the proportion of 65 years old and above has increased from almost 11% in 2010 to almost 20% in the recent years. That means more money and more resources have to be devoted into maintaining a higher vaccination rate among the elderly. So while the vaccinated elderly numbers have doubled over the period, actually the vaccination rates still were lower than 50%, far than optimal and limited also in increase. If you look deeper into the good years, we have two good years in 2016 and 2019 when the vaccination rate substantially increased. These 2 years were pretty much driven by the perception of the higher risk or better vaccine. In 2016, you see there was a big spring influenza outbreak ahead of the vaccination season, and that caused a lot of the morbidity and the mortality, also overwhelming healthcare system. So it triggered the public, especially the elderly, to perceive that the influenza is more dangerous than before. And that helped stimulate a much higher vaccination rate in 2016. In 2019, another twist was we followed the international guideline to switch from trivalent flu vaccine to quadrivalent vaccine. And because of the media coverage, the public perceived that the change was toward a much positive side. It's a better vaccine with more protection than before. So that also helped stimulate a uprise of the vaccination rate. But also, if you look at the downside, the bad years, other than the COVID impact in 2021, the other two bad years, 2018 and 2024, both seeing a unique vaccination safety event, which is the discolorization. So the safety concern was still higher, and it triggered public fear of adverse outcome. Although in the end, the investigation showed that it's just a single event, it's not a systematic event, and it also doesn't affect other doses in the same batch. But the public image of unsafe vaccine has already been resulted, and the widespread media coverage has triggered a lot of public fear. So it's very difficult to recover that in a short time frame. I'll use the very latest season to illustrate the phenomenon of this unexpected event. Here you see the red curve indicates the vaccination increase during the most recent season, and the blue one indicates the previous years. Some of these unexpected events include the typhoon related clinic closures at the beginning of the campaign, which led to difficulty in accessing in the beginning. And very much later on, the discoloration event happened, triggered a lot of the media coverage, leading to further decline and reduction of the uptake. So in the midterm, actually, we saw a wide gap of more than 120 to 160,000 doses gap compared with the previous year. But what an interesting twist was right after the Lunar Asian New Year in February, a headline news hit the Mandarin-speaking world that the actress, very famous actress Barbie Hsu, suddenly died from influenza complications that developed into pneumonia while traveling in Japan. And this widespread news coverage led to a big surge of people seeking influenza vaccination. During that time, the vaccination in stock was already not much, so the panic triggered surge resulted in shortage of the stock, and suddenly influenza vaccine became a very wanted item. Everybody wanted to receive the influenza vaccine. So in response, we had to purchase additional 100,000 doses as a response. And once the additional doses were released, it was also rapidly vaccinated to the elderly population. So it indicates that the media can be hazardous to the campaign, but can also be sometimes beneficial. So I just want to briefly summarize that the challenges that have been encountered recently, of course, vaccine hesitancy and the media impact, I think is the number one. It can be hazardous, but can also be beneficial. So it's important to harness the media impact by creating and strengthening public-private partnerships to build up vaccine confidence among the public. And also, in case of these special events, there were already established multi-stakeholder mechanisms for us to act quickly and jointly and be transparent to the media and to the public about any vaccine-related event or misinformation to ensure the public trust is still there. Of course, we need to expand access and increase convenience, so school community outreach is still crucial. And recently, we have combined COVID vaccine and the pneumococcal vaccine all together with influenza vaccination campaign, so the clients can be co-administered with those vaccine all together. It's also important to insensitize the healthcare system, healthcare providers to vaccinate the high-risk population. And structurally, we have worked with the Health Insurance Administration and also long-term care authorities to include the influenza vaccination rate as very important quality indicator or accreditation indicator, so they have more momentum to vaccinate their chronic patients or residents. Last but not the least, it's still important to go with the international trend and upgrade your vaccine timely. We have finished the cost-effective analysis and determined by our ACIP that changing to adjuvant or high-dose influenza vaccine for the elderly is cost-effective and should be regarded as a prioritized policy direction. So we have been working hard to advocate the financing input and the public willingness to change in order to smoothen that kind of change in the next few years. That's my presentation. Thank you very much.
Thank you very much for sharing the experience, Dr. Yin Chung Lo. Super relevant to see the issue of trust on vaccines. No? Now I invite our next panelist, Mr. Seong-Yoon Louis Kwon from the Republic of Korea, Deputy Director of Korea Disease Control and Prevention Agency, to give his presentation.
Good afternoon, everyone. It is very pleasure to meet you all, especially with this meaningful policy dialogue on immunization, especially on influenza. So first one, I want to share what the policy measures that we are actually implementing in Korea, especially for the influenza. The first thing is always about the NIP. So our national immunization program covers not only elderly, but also the children and the pregnant women, which is also really important high-risk groups. And also, we try our best to enhance the accessibility. So the free of charge is really important. At the same time, the proximity of the clinics and also the healthcare centers are really important. So we try to expand our accessibility as much as possible to expand the designated hospitals and clinics in Korea. And also, not only about the immunization, I also wanted to mention about how we try to lower the influenza disease burden using the different measure. Like when we actually have the surveillance of the ILI, and once we found the ILI threshold has been increased, and then we alarm, and then the entire National Health Insurance Service actually provide the coverage system for the high-risk group. Not only based on the testing result, but also more like a proactive measures to actually reducing the disease burden of the influenza. So that's also the key to actually we can reduce the disease burden of the influenza. And I also want to mention what is really important of the surveillance. So not only the sentinel surveillance that we have, but also the lab surveillance and also the hospitalization and the severe illness surveillance. It's more like a multi-year and multi-level of the surveillance so that we can actually accumulate it, what the evidence is actually needed to be make the decision. And also, those information have communicate with the vaccine effectiveness analysis. So it coordinates how much implementation actually works in Korea and which is not really works. And also, I want to mention about the immunization registry system in Korea. Just briefly mentioned by the Charlie that Japan recently tried to mobilize their registry system, not from the municipality, but for the central level, which is really important to have kind of bigger and whole picture of the entire nation. So what the Korea is actually advanced is based on that registry system, we kind of real-time based the vaccination coverage that we collect and then try to have more targeted intervention toward the subgroup or the uncovered vaccination coverage. That's what we are trying to aiming more precisely. And what we are trying to do is more like a perception measure as well, as the Dr. Tan already mentioned about actually, even though we all have the hard evidence, it's really clear, crystal clear that all the evidences are really resonate to us that we need to implement the vaccination, but still it's not really get reached to the public. So the science to public is really important as a communication measure. So what we are trying to do is not only about monitoring the vaccination coverage itself, it's quite a bit shallow. So we need more deeper analysis, like on what other kind of main causes or the deeper roots of the factors that as a barriers or the enablers. So what we are trying to do from this year, even though it's a pilot study, but we are trying to have a Korea initiative of the immunization survey. So it's more like have a designated survey for the nationally representative sample so that we collect more rooted causes or the enablers. And especially we have two different modules. The first one is about the children vaccination, which is really classic NIP program, but also the seasonal vaccination program. So what we are trying to do is after the pilot study done, then we trying to have a nationally representative sample survey about those insights so that we can actually communicate with our decision makers properly with the evidence-based. And also, I really agree with the need for the enhanced immunization tool, which is the high dose and also the adjuvanted vaccination. So what the Korea is currently doing is trying to monitor very closely with those effectiveness and the safety profile of those vaccines. And hopefully we can even have more data and the evidences that we can make the right decision. Thank you very much.
Thank you very much. Very relevant information about the importance of data for informing decision-making, for communication. Great, thank you again. Now, I will invite again Dr. LJ Tan to the stage for our discussion. We have a series of questions, so I'm going to move there. So thank you again to all panelists, and perhaps the first question I have for each one of you is, what strategies has your economy used to reduce the burden of influenza in elderly populations? If you can give us kind of like an overview of the comprehensive approach you have used in each one of the economies. Thank you.
So first of all, I already kind of briefly mentioned about what we are doing regarding the NIP, but I wanted to highlight a specific target group that we really think is important, which is the long-term care facility residents. They are the high-risk group, and we all kind of witnessed how much the devastated impact can be during the COVID-19 pandemic. So what we are really eager and enthusiastically implementing our strategy to those target group is trying to outreach them with the local governments, because they have their own kind of networks, and there is the opinion leaders and also the senior groups. So the local governments actually have more close connection with them. So it was really important to actually reach out through the local governments to the target group. I want to mention that.
Oh, good. I think some of the examples that we can use from the United States are also very applicable to some of the economies. In fact, one of the things that Mr. Kwan has talked about is some of the things that we do. We look at long-term care facilities, right? Because that's a very low-hanging fruit, right? If you think about the fact that all these 65 and old people who are in long-term care facilities are all there together, you can get them all at the same time. That's an approach that we use in the United States as well. We try to target the long-term care facilities. That's one way. But the second and bigger way that we look at this in the United States is obviously a lot of our patients, 65 and older, they're more compliant. They tend to want to get vaccinated. So for them, that means access. We need to find ways to make sure that, this more compliant population, you don't have to work so hard to get them vaccinated, right? This is not like the 35-year-old person who runs marathons, right? You need to make sure they can get access. So in the United States, one of the things we've tried really hard to do is improve access in two ways, right? Continue to make sure that vaccine gets paid for. So in the US, 65 and older, Medicare covers for all vaccines. But at the same time, one of the things we did was to make sure that when a provider gives the vaccine to the patient, they get paid. Because if they don't get paid, they're going to be less likely to want to give the vaccine. So making it free to the patient, but making sure that the person who gives the vaccine gets paid as well. So that's one important way to improve access. The other way to improve access is to broaden points of access, right? So not just through a medical provider office, but through pharmacy. And so in the United States, the use of pharmacies to increase access for 65 and older has continued to climb. It used to be a lot of influenza vaccine was given in medical provider offices. That's begun to go down, and there's been an increase in the number of 65 and older going to pharmacists to get vaccinated. And that makes a lot of sense. If you think about an older person who is working, moving around with his or her friends, they go to a pharmacy to go shopping. At the same time, they can get vaccinated, right? So this is not to say we don't want to do the providers, but we want to make sure we have more access points so that people can get vaccinated.
Great, thank you. Which touches on the importance of convenience, no? Like patient-centered or people-centered approaches. Great. Dr. Yi-Chun Lo, the same question for you, please.
Yeah, for us, it's free vaccination, free antiviral for the elderly. And I want to emphasize that the antiviral prescription has to come from healthcare provider, but it's not testing based. So in order to remove the barrier of having an influenza rapid test positive in order to be prescribed during surge season of influenza, usually in the winter time, we actually open that barrier up for the healthcare providers to prescribe based on clinical and epidemiologic consideration. And also long-term care facility, infection control and prevention and outbreak management. And I think something I want to add is during surge season, it's important to ensure the healthcare system is still functioning without being overwhelmed by influenza epidemic. So we usually encourage and implement diverging services to avoid that a lot of these mild influenza elderly patients rush into emergency department and overwhelm the healthcare services, especially during our winter-long holidays, such as the Asian Lunar New Year season. So those are some of the strategies that we constantly implement to reduce the influenza burden among the elderly.
Great, thank you for sharing.
Hector, can I say one more thing? It was mentioned by Eric, and that is, in the US, I'm sorry to interrupt, but I think it's important to point out that we didn't hear a lot about it, but quality measurement in the United States is used a lot to incentivize providers to give flu vaccines. So I think we shouldn't lose that as a strategy as well. I think it works for everyone, right? You can tell the doctors that if you do this, we'll pay you more. Or the other way you can also say is that we have these standards, and if you don't meet those standards, there are consequences as well.
Yeah, the importance of incentives, no? Yeah.
For incentives.
Yeah, you took me out of the script, so I don't know what I'm going to do now. But yeah, no, thank you very much. Very, very relevant comment. The second question that I have is related to kind of like real life examples. Like, can you share within your economy what role data has played in shaping policies and decisions? Like maybe just one real world example, like we got this data and we reacted or not in this way. Thank you.
Should I say? Among other things, I want to mention about the vaccination effectiveness analysis, the importance of it, especially Dr. Cheong as a chair of our entire NITEC committee, but also she's controlled the entire influenza vaccination effectiveness analysis program, which is what we call HIM. And actually, I think it is really important to have a localized effectiveness analysis because the demographics and the house behaviors and entire, the socioeconomic status, all are different. And all of them are really important enablers or the factors affecting those effectiveness. So it is really important to have a very localized and kind of not real time, but really recent data about the vaccination effectiveness can really echo what kind of intervention that we can actually do. And what I really fascinated about Dr. Cheong's effectiveness analysis is because they actually do the two different stages of the effectiveness analysis. First one is the interim report, and then the final report. So that even the interim report can kind of resonate or communicate with the WHO, like what kind of seasonal influenza subtypes are really, circulating in Korea, and how was the effectiveness matches has been perfectly matched or not. So those kind of information is really needed and important to our vaccination policy decision.
I'll go next, I guess. I think surveillance data is extremely important, especially if you can get real-time surveillance data. So what we use in the United States is we can kind of see how the virus is spreading across the country. And by knowing the surveillance data, we can actually prepare the providers, and we can also prepare media so that we can kind of promote vaccination to the public, right? Flu is coming. It's here in the Southeast. It's coming up to the Midwest. You need to be ready for flu. So surveillance data, I think, is really a good way to kind of harness the entire group of all the parts of influenza, media, providers, the public, pharmacy, get them all ready, right? But I think I say that because I want to point out also the importance of surveillance in terms of developing economies as well. I think it's if you do not have surveillance of disease, it's very hard to make a case to protect against it, right? I think I had the privilege of working with Apache about 10 years ago now when they were working in Thailand. And I think it was brought up as one of those examples where Thailand has really invested in data. I mean, it's remarkable. When I was here 15 years ago talking to some of the developing economies, the response I get was, LG, we don't have influenza, so therefore we don't need to vaccinate. Well, have you looked is the question you answer with, and they say, oh no, we just know we don't have it. So I think surveillance is so important. From my perspective in the US, it helps us with planning because we do all that. But I think in terms of developing economies, You need that data to know that you've got flu. That will then help you decide how you want to protect your public against flu.
Perfect. Dr. Law?
I just want to add that number one, vaccine mismatch or match surveillance is very important for us to guide the switch from trivalent to quadrivalent vaccine in 2019. And furthermore, it also helped guide all the economies to change back to trivalent because the disappearing of of certain B lineage. Number two, also based on the surveillance of clinical cases, we're able to differentiate the vaccination rate of the severe cases. Constantly, it has been showing in my economy that although we have vaccinated up to 50 or 55% of the elderly population, among the elderly severe cases, only less than 10% were vaccinated, which shows a very disproportionate affecting the unvaccinated part of the elderly population. It also serves as evidence to persuade the public and the elderly community that vaccination can be working and effective against severe disease.
Perfect, thank you. Before we open the microphone to other APEC economies that might be willing to share their experience, maybe I will go with the last question of this panel, and we'll go in a reverse order, starting with Dr. Yi-Chung Lo. We have heard a lot of recommendations, potential recommendations, some emerging messages from the evidence. Out of all those, that list, like a shopping list or wish list, which one is kind of like the one that resonated the most to each one of you? So maybe we can close with that part of the panel. Thank you. Let's start with you, Dr. Yi-Chung Lo.
I think the most difficult one is still to maintain the public trust, especially the elderly's trust in the vaccine safety and the vaccine efficacy. Especially, I think in my scenario, the elderly population are more concerned about the vaccine adverse effects, and they are pretty much easily triggered by any media coverage of these events without direct linkage and causal linkage, but already trigger a lot of the public panic, and the resulting damage is usually difficult to repair and recover. So I think I will stay strengthening and build up more and more partners in enabling vaccine confidence is the most important thing I want to emphasize and striving to do. Thank you.
Great. Trust.
That was going to be mine, so I'm not going to say that now. So I'm going to talk about provider confidence then. Let's talk about that, because I think it's important that we help our providers, because they're the ones that talk to the patients. So we want to make sure that they have everything they need to tell the patients what's best for them. So in that respect, I think data is extremely important for the providers. I think if you think about 65 and older specifically, right, there is now very good data. Enhanced vaccines will improve effectiveness and save lives. So we need to get that data into the hands of the providers so that when they talk to their patients, they can say things like, we actually have a better vaccine. And that is actually a good marketing comment, right? I can tell you, I've got something better for you, right? They're going to say, okay, what is it? I want to hear about it. So I think we need to give that data to the providers. I think there is an excellent study that we're going to hear results from called DanFlu 2. It's coming out of Denmark. It's going to show the improvement, the benefit of enhanced vaccines. So I really look forward to that. But I think data to the providers so they can talk to their patients.
Data, great.
I would say an empathy. Like sometimes people are talking about because of the health literacy, maybe the perception is not really reached out to the public. But I would say I'm more on the side of we need to really focus on the empathy, because that's how we really can make the people to move to the better choice. And regarding the empathy, I also want to, even though I'm a government officer, I'm on the more on a side of a behavioral change is really needed to be done by nudge, not by a mandate. So a free of access and easy to come to vaccinate is really important as lowering the barrier. But at the same time, I just want to introduce one of the cases. It's not about the immunization, but in Korea, what we do for the crosswalk, we all know about the smartphone zombie. Like, we always looking at the smartphone, and we really don't want to make the traffic accident in front of the crosswalk. So what we are doing is, instead of making them give some fine when they are seeing the smartphone, but instead of that, we installed LED lights in front of the crosswalk, so that the people kind of not even intentionally notice that the light has been changed, so that they can cross safely. So I think those kind of nudges need to be done, not only for those kind of infrastructure, but also about the immunization policy. So that can be done based on the empathy from the public officer, and also the healthcare providers, and also the academia.
Great. Contextualization, adaptation, tailoring things to the needs of the economy and the population. Great. Now I invite participants from other APEC economies, either online or here, should they want to present or comment on specific successes, innovations, challenges in addressing influenza and other adults. Good. Since I hear none, then let me please give a round of applause to our panelists, our contributors, our speakers online and here in the room. And these insights, all the insights we have heard today, will help us with the final recommendations. Now, I will invite for closing remarks, Dr. Victor Joseph Mel Campos, Chair of the APEC Health Working Group, Director General of the Office of International and Technical Cooperation at the Ministry of Health of Peru, for some closing remarks. So, bienvenido, welcome, Victor.
What an amazing panel. We really enjoy. Also, I am a physician, and as a healthcare professional, we support vaccines. Our boards, I remember, is mandatory the vaccines, especially the flu vaccines, for not only elderly people, but for pregnant women, for people living with HIV and children. And it's so mandatory. When you visit my homes one day, my Wi-Fi and my password is "get your vax." So I would like to thank you, all of you, for being here in Cheong, and also for joining us online. It is truly an honor to participate in this vital policy dialogue today. As a chair of the APEC Health Working Group, I want to express my heartfelt thanks to all the speakers, the panelists, and participant economies. Your contributions have made this discussion rich and timely. We've heard today that the impact of influenza on older adults is more than just a health concern. It is a challenge that touches all aspects of our lives. We want our grandparents healthy, but also our economy healthy. It affects our hospital systems. It affects families. It affects communities. And it puts a strain in our economies. Importantly, we learned that flu vaccinations do more than protect health. They save costs for health systems and enhance the overall well-being of society. We have effective tools at our disposal, like surveillance vaccination programs, outreach efforts that we can use more effectively to safeguard our elderly citizens. This dialogue shows us that progress is not just possible, it is happening. Economies across APEC that are implementing stronger immunization strategies, improving surveillance systems, and building public trust. The insights we've shared today will be used to create a recommendation paper and also which will guide future policy making, strengthen cooperation among economies, and help us implement what works best. Let me stress that Health Working Group is dedicating to supporting our members' economies in promoting resilient aging and preparing for pandemics. We really like the strategy. We put a high-dose influenza vaccine together with COVID-19 vaccine and pneumonia vaccine. We really appreciate that. Our works align with APEC's goal of inclusive growth, healthy population, and regional collaboration. Thank you again, once again, for your participation, your ideas, and your commitment to reducing the impact of influenza on our elderly. I invite you now to join us for the reception at the Sheraton in the Lotus Room 1 and 2 on the 3rd floor. Thank you.
I think before going to the reception and taking a group photo, which is the last invitation, the delegation or delegates from the Economy of Malaysia would like to share very briefly their experience, and I think that's pretty valuable. So if we can open the camera or the microphone for them, please. We can hear you. Thank you for sharing.
Yes, good afternoon.
Yes, we can hear you.
I'm Dr. Noraliza from Ministry of Health Malaysia. Just to like to share with all of you here regarding Malaysia influenza vaccination program for older adults. So currently, we already adopted a life course immunization approach actually to strengthen our universal health coverage. So we try to assess this immunization in terms of preventive care across all the ages, okay? And we have already launched our national influenza vaccination program for our older people, which is age 60 and above. Some of the APEC economies started at the age of 65, but for us, we start at the age of 60. But there are certain criteria. The 60 years old should have at least one comorbidity. We started this immunization program in February this year, and it's actually aligned with our National Elderly Healthcare Services Action Plan. So, in terms of epidemiology, Malaysia, the seasonal for influenza is less defined compared to those who have 4 seasons. It tends to occur all year round. So, actually, it's not a notifiable disease in Malaysia, but of course, if there's any outbreaks or cluster, it shall be reported from time to time. We only have surveillance in our system, which is for the influenza like illness and also the severe acute respiratory illness. Currently, we only have not practiced yet a population-wide routine influenza vaccination program. We started with elderly first and also healthcare workers. We would like to share some of our key achievements here. As I mentioned just now, the program has been launched in 18th of February this year. We actually are able to procure a free influenza vaccine for about 170,000 doses currently, and we have already vaccinated about 140,000 older people which has the comorbids. And right now we see that we are going for outreach and also through the the long-term care facilities, of course. And for the challenges that we have, of course, just now has been mentioned by one of the panelists, we have some vaccine hesitancy from our older people because of the COVID-19 experience. But despite of them, we are trying to see the sustainability in community engagement and also in our health education. We also have some challenges in terms of recent surge of demand in February and also March because of the high profile flu cases. Actually, it's just a temporary localized shortages. So we are looking into a timely procurement now. In terms of recommendation, I agree with the APEC economy. There are some of the recommendations stated by the panelists and also from the speakers. Thank you very much.
Thank you. Thank you. Much appreciated. So, thank you again to all our speakers, panelists, and participants, both in person and online, and for your commitment to advancing healthy, resilient aging in the APEC region. So, please, let's take a group photo. And again, you are all invited to the reception at the Sheraton Grand Lotus Room 1 and 2. So we hope we can see you there. Thank you.